Today we are explaining the transrectal biopsy of the prostate for raised PSA. The MRI report shows right side peripheral zone, nodule present at the base as well as the mid prostate region. PSA is 34. Dr. Soundarya is doing for last 1 year. After we have taken the BK ultrasound, we could do biplanar visualization and take biopsy in predominantly sagittal plane. Previously, when we had Philips ultrasound, we used to do the axial cuts. The important difference we are understanding, sagittal cuts are very important because it takes most of the periphery. With that intent, we are sharing. It's not the question of BK mission. If any mission has biplanar approach, it is better. Most of the Indian missions, they have trajectory, but biplanar will not be there. When we have taken this mission, we could understand what is the transverse plane, what is sagittal plane, what is axial plane. In fact, all the details practically we are discussing here. Hello Soundarya. I wanted to know what are the basic things. I don't want to go into the details of the mission. What is this 8818?
This 8818 indicates that we have connected the endorectal probe. There are two probes which can be connected at a time on this mission. One is the abdominal probe, that is
This is abdominal probe.
This is the abdominal probe.
This
and
is
this
the,
is the
that means on the back side here, can we connect both probes?
yes, at a time we can connect.
At a time we connect and we can switch over for abdomen as well.
Yes.
That means you can see the bladder, you can see the prostate also.
Yes.
So 8818 has two probes at a time can be seen in the screen as half. That is one is the transrectal probe, another is abdominal probe. What about T? What is the T?
T, S and E are the ones. This T stands for transverse. This is sagittal and end firing views.
And normally when you do transrectal biopsy, what are the two positions you will keep?
First, we keep in the biplanar mode. Both transverse and sagittal can come simultaneously. So we know where we are going exactly in the sagittal plane as well as in the transverse plane.
Okay.
That comes with this part of the probe.
Can you show the probe details here? Have you applied condom on this probe?
Yes, we have
What are
applied
the
two condoms.
two entry points of the needle?
One is this end firing,
Yeah.
which comes by the side of the probe.
Okay.
And this part of the probe is the one which visualizes the axial cuts.
Yes.
And this end firing, this is the needle
So if
guide.
I am like this, it exactly end fires.
It end fires.
What about the-
with this we are seeing and we are taking
End
end
firing.
firing. Whereas there is one more needle guide which goes across this probe
Where
and
it is
that
coming out?
exits here.
That means this has channel inside.
This has
And
a
that
channel
comes
inside.
here.
Here and with
And
this
if I
part
keep like this, it fires side.
it fires
it will
side.
not fire end.
Yes. With this part of the probe we get biplanar, that we get two views, both transverse and sagittal, through this part of the probe.
This is only
axial
axial.
end firing.
This is sagittal and
Transverse
transverse.
side firing.
Side fire.
This is the side firing needle guide.
These two probes, when you put needle, it comes on the end. When it comes here, it goes through the probe and comes on the side, which shows this vertical length side will show the sagittal as well as transverse, whereas this show axial. Now, when you insert the probe, what is the position of the probe you have to put? What are the two buttons we are seeing here?
So these are the two buttons. One, if the upper one, if we press, it can switch to the end firing, or if we give a long press, it will go for the side firing also. Sagittal.
Yeah, these are transfer.
This down one I have pressed, it has switched to the sagittal mode, that is side firing, and the upper one I have pressed, it has gone to end firing. The
Okay.
difference is this blue dotted line indicates the trajectory of the end firing, this longer one,
Okay.
which comes here.
Okay.
Whereas this one dotted line in the center indicates the side firing, which goes through the probe. the needle guide goes through the probe, it is seen as a dot, just like a CT section.
Okay. Now what about the, you keep the probe there? What about the other things which you are, it's a sterile,
Done under sterile
it has to be done under sterile condition. Do you give proptolysis enema or one plain dulcolax or nothing?
We give Dulcolax for 2 to 3 days pre-procedure and one antibiotic for 2 days before.
Oral antibiotic?
Oral antibiotic and Dulcolax. We don't give any.
Urine culture, is it mandatory?
We send the urine sample for culture. If the patient is asymptomatic, under IV antibiotic cover we give.
On the day of the surgery, will you give antibiotics?
Yes, 1 hour
Okay.
before the procedure, IV antibiotic.
What is the routine, the biopsy needle and biopsy gun which you are using?
This is the gun which we use for prostate biopsy. The length of this needle is 22 centimeters and the core which is coming through this, it measures about 18 mm.
18 mm.
18 mm.
The length of this is?
The length of this is 22 to 25 centimeters.
Okay.
And it is 18 gauge needle and the length of the core which we can get is 18 mm.
Can it be reused or it is disposable?
It is disposable, single use.
Single use. What are these?
These are formalin filled bottles. We usually take 12 core biopsy, but if there is a particular lesion in the MP-MRI, Pyrites 4 or 5 lesion, we do targeted biopsy with MRI cognitive fusion. So we take additionally 2 to 3 cores in that particular area. This particular patient has already undergone a biopsy 6 months back, but it came out negative. So we are doing a saturation biopsy with 22 cores in view of rising PSA.
What about these small things?
These are the tissue paper which is cut into small pieces so that while the needle is retrieved, we take out the tissue and we see whether the prostate specimen length of the core is adequate or not. After seeing, we drop it into the
And it also
formalin
avoids
bottle.
the formalin touching of the...
Avoids the formalin touching.
Now, when you come to the procedure, what is the position of the patient you have kept?
The patient is placed in left lateral position.
Without identity of the patient, with the educational purpose, we are showing this. This leg is flexed a little bit. This leg is flexed a little bit. Do you inject Xylocaine jelly 10 minutes before?
We inject Xylocaine jelly locally, just 5 to 10
Do
minutes.
you do
before
any
the
injection
procedure.
of this thing?
If the patient does not tolerate the procedure, then we can plan for local block, which we do with the PCNL needle. Otherwise, if still the
The
patient is
PCNL
not,
needle can be used through this?
yes, we can use through this.
Okay. So now you insert. While insertion, what is the probe position?
While insertion, this is the that is the transverse and sagittal part will be seen through this. This concave part of the probe will go through this along the angle of the rectum and anus. That is, we insert like this and then we turn towards the lumen of the rectum. Until we see the seminal vesicles, we have to introduce the probe.
Can you introduce slowly?
Initially, we do a digital rectal examination. We assess where the nodule is. Then, based on that, we use the probe.
Yeah.
Some gel.
Digital examination to see where the hardness.
Yes, sir.
Right side, left side.
Yes, sir.
The top part of it is the right side, bottom part is the left side.
side.
This is the anterior, this is the posterior.
Yes, sir.
Okay.
సార్ మంచిగా గాలి తీసుకోండి మోషన్ రాస్తా నుంచి చెక్ చేస్తున్నానండి
You are inserting the probe with finger guidance,
ఎస్ సార్
rotating
ఎస్ సార్
and directing change.
లైక్ దిస్
Now you are showing the mission here for the convenience. What are these structures you are seeing now? Is it sagittal or what image it is?
This is transverse.
Transverse.
This is transverse.
Transverse.
Prostate small size gland we have taken.
Is it small size gland?
Yes, it is small size.
So if you want to change medium, you can change like that.
Yes, sir. We
Like
can.
this here, if you click,
Yeah. In
you
that
can
case,
say
the frequency
prostate medium and large.
This small has a 12 megahertz frequency.
12 megahertz. If I
If we
press
change to medium,
medium,
then the frequency is reduced and the area covered is wider. That is 9 megahertz frequency.
okay. So you want only small in this case.
Small.
So that the frequency will be more.
More.
So that you can see the nearest part better.
Yes, sir.
So now this is now in the transverse position. What is the difference between axial and transverse? Are they same?
The image will be the same.
Image will be the same.
But how the biopsy needle gun, how it comes is different. That's
Different.
all.
So this is transverse where you are seeing two seminal vesicles deep inside the rectum.
Yes, sir.
This is rectum.
This is rectum.
This is rectal
bladder.
wall. This is bladder.
Yes.
It is filled.
Yes.
So do you want a heavy filling or medium filling?
Medium filled bladder.
These two
Comfortable.
seminal vessels are meeting in the center.
Yes.
In a transverse.
Yes, sir.
Now you want it to come down in transverse?
Yes.
Come down. You are
Coming
seeing the
down.
prostate?
Seeing the prostate. The architecture is altered, so we are
So
not able
this
to
is
clearly appreciate.
this is the
This is
something.
the
This is the
outline of
prostate.
the
Outline of
prostate.
the prostate. I am able to see.
Yes.
What are these white ones? Calcifications.
Amnesia.
Corporamnesia or calcifications.
Calcification.
So this is the peripheral zone.
Yes, this is the
Yeah.
peripheral zone.
This horseshoe type of is peripheral zone,
Horseshoe type is peripheral
and
zone.
it is not coming anteriorly.
Not coming anterior.
So this central zone is transitional zone.
Yes, sir. That is transitional.
And now you are coming back a little
I'm
bit.
coming a little bit back.
You are coming
I'm
back.
slowly coming back to the apex.
This is apex,
Yes, that is
where
the
there is no differentiation.
Yes, there is no differentiation.
And
Still
this
down
is
is the urethra.
This is the bulbar urethra
Bulbar
or maybe
urethra.
membranous urethra.
Yes. And
And
outside
you
is
are
the-
almost you are
Yeah.
outing.
Yeah.
And now if I do biopsy, sorry, come down. If I do biopsy like this, one here, it will give periphery.
Yes.
Then why do you need sagittal section? For example, these two periphery, if I take biopsy in axial cut,
Yes.
in like what we do in monoplanar,
Yes, sir.
does it have any disadvantage?
The length of the peripheral zone will be much bigger in case of side firing,
Side firing.
as we get in sagittal view. Now
And one more thing, reaching this extreme end is difficult.
like this I can rotate to reach the extreme ends.
Okay.
And in this view,
This entire length of periphery you will get it.
yes, this entire
Whereas you get only a few millimeters of the periphery
one
here.
third of the length will
One
be
third of the
peripheral
length.
zone, less all will be anterior transitional
So
zone.
this is a sagittal view. This is the axial view.
Yes.
Now let us go to axial view only. This is the only axial view. Can you go to the bladder again? This is the bladder. At the level bladder, if you are going away towards the rectum, two seminal vesicles, come down slowly. Now seminal vesicles are ending. Now irregular bladder is seen, irregular gland is seen here, maybe bladder mucosa. And this is the first outline at the base. Now come down, this is the urethra. This is the middle part of where large gland is, rotate center. This is the large part of the gland where you can see a little bit center. This part is which side?
This is left side of
Left
the
side.
patient. This is
Right,
right side.
opposite of the screen.
Opposite of
So,
the screen.
because you saw how to, if you put down, it is showing the
Yeah, this is right side of the
This is
patient.
right of the- this is right side.
of the patient.
This is left
side
side.
of the patient.
So,
I'm
you are
rotating
putting-
the probe anti-clockwise.
Yeah.
I come to the right side of the
Right side.
patient. I rotate the probe clockwise. Then it comes to the left side of the patient.
left side of the patient. Okay, it's a clockwise, anti-clockwise rotation. It is because you are showing in. If you turn down, if you turn down,
If
what
I
will
turn-
show? Down, it will show the right side.
But if we
This is the right side.
if
If
we
you are axial cut,
Yeah.
if you show up, what will happen? Left side will
I
happen.
will
Go
change
inside.
to axial answer.
Even in axial, can you show in axial?
Yes, I will.
This is transverse. Transverse and axial view are same.
Yeah. But the movement to see right and
Yeah.
left.
Show
will
me
be-
now. Show me the axial.
Now this is end firing. Now I am coming back. I am seeing the bladder and seminal
This is
vesicle.
sagittal view.
This is sagittal view. I have to rotate and get the
Now
axial
you are
view.
rotating, you are getting axial view.
Axial view.
This is the urethra,
Yes, that
which is
is-
going into the bladder.
Yeah,
This is
now-
a perfect axial view.
Yeah,
Now
axial
what
view.
is right, what is left?
Now this I am doing
This down,
This
then
means
this is
this-
the left.
this-
So in axial, if you move up and down, see this is the right.
Right.
So in axial, it will be opposite.
yes.
Whereas in the transverse, it is same.
Same.
So transverse and sagittal are one.
Yes.
Axial is one.
One.
So transverse you don't need. You basically need axial, but axial also not needed in side firing. Only axial is needed when you want to do
End firing.
end firing. That happens when
When an anterior fibromuscular stoma tumor is there,
anterior fibromuscular stoma or
transitional
prostate
zone-
has to be taken. So very clearly, we have three options here. One is axial. In axial, you will see directly towards the gland, where you go vertically up, where you can travel the transition zone and go to anterior part. Anterior part. For example, this is anterior part, this is posterior part. Entire length can be traveled, but the periphery of the tumor is very less. What about the sagittal? Is you fire this thing vertically, so that entire length the piece will come. The transverse is only to see where the point is entering, isn't it? Now let us start the firing. Now which first where you wanted to take, base or middle or apex?
First base, Right
now
side,
can you show the
bladder.
base?
Yes, sir.
Now can you show this is seminal vesicles. Now this is the prostate. This is the seminal vesicle. You come back. This is the center is showing where it is. It is in the center now.
Yes.
Come back. You have to rotate for that.
No, I'm just coming back.
Coming back. This is the base region.
This is the
In
base.
this base region, if this needle goes to this side,
That is right side.
right side,
Lateral.
lateral. Now in this plane, can we see in sagittal?
Yes.
Both I mean to say. Now this is
Biplanar.
sagittal.
Yes.
Biplanar at the base. This is the only small base, periphery.
Yes.
After that, you will come to center, like this.
Right side,
First you go
base,
to the
medial.
right. First you go right side, extreme lateral here. Can we help you?
Yes.
And you take this thing. I will help with the gloves, and I will insert the. Do you think that insertion should be done by other person?
Yes. For stableness.
Stableness. Stable this thing. Now, how will you see that whether the prostate is touching here? Here you can feel.
Yes.
And here also you can see the needle is coming here.
Yes, yes.
This is the base level. Small amount will be there.
Yes, sir.
You are in the periphery. Can you fire? See, don't remove. See, almost it has base level, mucosa, periphery, and bladder up to it has gone. Take out. I am taking it out. I am pulling this, and this is the piece which we are showing. Close. Top lights on if necessary. This is a piece which has come. This is a piece. Big piece has come. Can you see this piece? Now I will put it in the, what is this, number 1? Number 1 I am putting into this.
And one person
No?
will be noting down what all.
Number 1
Areas
is
we have.
base right side lateral. Base right side lateral. Now you are going to the base
Right side.
medial. See, this is the spot which is slightly medial. When it comes here, see, large amount of the this thing is there. Large amount of tissue will come now. This is the second piece. Now we are putting like this, and we are putting on it. Nicely piece has come. Can you see it? Top light on.
Not top right.
I asked to. Are you able to see? Okay. This is the second one. Second one is right base to the top lights off.
I have rotated in clockwise
Now
direction.
this is very important. In sagittal
Earlier
section, it was earlier anti-clockwise. Now if you rotate clockwise, you will go to the lateral surface of the or medial surface of the left side. That is the rotation. Can you show the rotation?
From
We were here.
This side.
We were here. Now we are going here. Now can you
Left side, base, medial. I'm taking.
yeah, can I insert?
No, this shorter one.
Shorter one. Okay, sorry. Okay. Left base here. See, left base periphery towards the urethra. Now patient is not wincing. That means you are not hitting any part of the. See, can you see the piece clearly? It has come. Now this is the median left base. So sometimes this. Now we have gone to the extreme lateral of the base on the left side. See, extreme lateral. This dot will indicate that extreme lateral. Is it transverse?
Yes.
Yes. So now this
is
is fired.
sagittal.
This is sagittal. These are the 4 pieces have come now. We first take 12 pieces. After that sextant. See, the nice piece has come. Now
Now
see,
I
you
have
are
come
coming back.
a
Coming
little
back. See, more transition zone is seen. Now this is the right
Right,
side
mid-zone,
extreme lateral, mid zone. Mid zone extreme lateral here. Fire. Yeah, that is fired. Now it is not going towards the bladder. Now again we are keeping this. See, good piece has come. Now clockwise towards the middle part of the prostate, sagittal section, transverse section. This needle says it will enter here. It will go obliquely like this. So patient is not wincing means the anal sphincter is not involved in this part. This is not under infiltrative anesthesia. Now we have moved more towards the clockwise. Saundarya,
Yes, sir.
para median, right side,
left
mid
side.
zone, left side, mid zone. Sorry, this is the left. Transverse cut, left will be shown. Now here the needle is touching, and then it came. Now we will keep it. The piece has come nicely. You can see. Go extreme lateral of extreme
Mid-zone.
lateral, mid-zone,
Left.
extreme lateral left side. This is extreme lateral here. Yeah, now it is fired. This is total 8 pieces. This piece also come nicely vertical piece. Now
Axial view we'll get, and this kind of blue dotted lights will come.
okay.
So the probe we have to withdraw. We are seeing the innermost part, that is the semivesical
Yes,
part.
yes.
We are withdrawing the probe,
Yes.
and then we have to rotate so
Yes.
that we get the
Axial
view.
cut. Rotate. Go to base and rotate again. Yeah. Now this is the base. Rotate. Opposite. Yeah. Yeah. This is a, yes, exactly. Yeah. You come back. Yeah. This is a urethra.
Yeah,
This is a seminal
semivesical.
vesicles. Come back in the same center. This is the prostate artery.
This is the
urethra.
prostate.
This is a pure axial cut.
Yes, this is
come
pure
back.
axial.
Come back. Come back. This is the apex. No. A little more inside. This is apex. This is
Yeah,
apex.
this is apex.
This is apex. Here.
This is base.
This,
This
this
is
is middle.
mid-gland,
This is
and
apex.
this is apex.
Here, if you do vertically, more peripheral zone will come. Like that. This blue dot. You wanted to say.
Yes, sir.
This blue dot will take more peripheral zone. Only thing is that right left will be different.
Yes, up and down movement we
Up
should
and
do.
down movement we have to do. For up will be right,
Up will be
right, and down will be left.
here. I have hold the probe in different ways. So up
Yeah.
is left and down is right.
Down is right. Okay. So that we have to note down. Now you are doing right or left first.
First, I'm doing
This is
Left side.
This is which probe? It will be end firing.
end firing.
End fire. Can you show
So
the end firing?
This
This
longer
is the
one.
end firing. You will go through this because the apex part come down a little bit. Yeah, this is apex part. The apex part will not be delineated very well. See this blue line you are able to see entire length has come here. Entire length has come here. So this is the axial cut. The write down.
Axial right lateral.
This piece has come little small. We will repeat the same piece. You cut the same piece. You go inside and come back. This is the middle part because urethra is seen.
Yes.
Now this little below. This is the
Apex.
apex. Don't change. I will insert. You don't change. You watch here only. I will insert and fire. You fire only on the periphery. You fire on the periphery. A little more inside because it's too. Yeah. Here insert more. Yeah, insert more. The needle has to, insert more. Yeah, now needle has come, fire. Yeah, now this is seen.
Yes.
Now the piece will come bigger because the rectal mucosa and the length is last one same thing you put it. Last piece same thing you put it. This has come now little more length. Usually in this part length will be little less when compared to other pieces. Now coming to the same paramedian. Here urethra can get injured.
Yes.
Then bleeding can happen because you will be close to the urethra. Now para-urethra, this is urethra, this is the para-urethral, insert up to here. It should travel, no, come back, yes, see here it is a rectal mucosa, come back, yeah, right, fire. No, that side, this is urethra, yeah, see this is para-urethral region. Here patient will have little pain, sometimes because you will be tilting towards the, see this has come a big good piece. You will be tilting towards the anus. Because of the pressure the patient may have pain. This is completed on the
Right side.
right side.
Left side completed.
Keep note that 10 and 11 are left side. Write down. 10 and 11 are left side. Now
Now
come
I'm
on.
moving the probe down.
Yeah.
So it comes to the right side of the gland.
Yes. Now go. See, can you show that? Go inside and show. Rotate first. Normal rotation. See, this is the left side. This is the
Right side.
right side. Now come back. Yeah, here. Little more this side. Little more this side. Yes. Now it. Yes. This is the needle coming from the rectal mucosa and it fired. This is the.
Right side.
This is the 11th piece. Nice piece has come.
Right side.
Right side.
Medial. Apex.
Apex. Now you are going. Can you show?
Yes.
Yeah. This is the urethra. This is the middle part. Come down a little bit. Extremely left. This is a difficult in axial position. Patient will have little bit of pain. Extreme lateral. Entire thing is peripheral zone. Entire thing is peripheral zone here. Now the mucosa is coming and hitting, and the peripheral part has come. Now what are the other areas saturation you wanted to take now?
Right side base.
Right side base.
Yes.
So right side base, can you change the position now? Light operates off. Now you will go to sagittal,
Yes, sir. Transverse and
transverse and sagittal. Sagittal also you keep. Both you have to keep. Now transverse you are coming, go inside. Yeah, rotate because you are rotated opposite
Yeah,
side.
I have rotated
Opposite side. Now you are coming.
Yeah.
Best thing is to see the seminal
Seminal
vesicles
vesicles.
and then come back to the base. Base. This is the base.
Yes, this is the base.
This is the base. Come back a little bit. In this base, you wanted to take where more? Right side or left side?
Right side.
Right side. So
right
you will
side
take.
base and left side entire peripheral zone they gave.
Yeah, this is
Left side
hypoechoic
full
lesion.
hypoechoic.
Can you show the hypoechoic lesion? See this irregularity. This
Yeah.
even capsule is irregular here.
Yes.
This area 3 pieces. This area 1 piece you want to take.
3 pieces.
3.
Saturation we have to take 22
3.
moles. Yes.
Okay. 3 in the suspected area on the right and left at the base.
Both end firing and side firing we take them.
Both.
Two side firing and one end firing also we take.
Yeah. So now you are planning to do side firing at the base.
Yes.
Right.
Right side.
This is extra.
Yes.
Okay. This is side firing extra at the base. Lateral first.
Lateral.
This
right
is
side.
lateral. This is lateral right side. Write down.
Yes, sir.
Yes. So this is the it has come but not very well. I think you should repeat because it has gone more through the you have to come
Capsule.
back more through the bladder mucosa. Yes. Same piece. So discard that. Yeah, this is in the periphery, but you should come back a little bit. Otherwise, the bladder mucosa. Yeah, this length we want. Yeah, yes, fire it. Yes, now it has come. So this is the piece which has come nicely now. Okay. Now you will take the same again
Medial.
medial, not too medial because periphery will be there more.
Yes.
Lateral. So okay, this is okay. Not towards the urethra. Okay. Yes. Now this piece will show the 15th piece. 15th piece. Here blood is coming at the same time. Piece is also coming. No.
No. Once more I will do.
Once more you take it. You discard this. So now you take a little bit back so that the gland will come. Are you inserting into the transverse probe only?
Yes, sir.
Yes.
Transverse side firing medial.
Side firing needle. Come back a little bit. Come back. Yeah. Don't insert more. Okay. If you insert more, patient does not have any complaint. Very cooperative. This piece has come nicely. This is the 14th piece. 14th piece is the
Right side.
right side
Base,
medial
medial.
base sagittal.
Yes.
Now axial you have to take.
Yes, sir.
So I will change it. Now I have to go to the end firing.
Yes.
You want to do end firing here to take the transitional zone?
Yes.
Yeah. Now you rotate whatever the way you want. Completely you are rotating.
Yes.
Go to completely you rotate. This is a little, it takes time to get oriented. First go inside the bladder. Yeah, this is the seminal vesicle center, and this is the urethra.
This is
Go
the
inside
prostate.
more. Yeah, bas. This is the prostate. Here you want to take this anterior zone.
Yes.
This anterior zone. Come back.
This
Come.
is the base of the gland.
Base of the gland.
Here?
Here is anterior zone. Okay. I will insert the. Don't change the position. I am doing in the axial. Axial. Which side it is? On the left side. You have turned the probe up.
Up means right side.
Up means
Right side.
up is right.
Yeah. No, this is not.
Left. Up is left. Okay.
So for right I'm coming.
Yeah. Right. You are coming there. Yes. Don't take right. Left only you take. We will write down. All you have taken. All you have taken right side, na?
Yes.
So right only you take. Come down. Yes. This is the confusion will be there. Only in end firing opposite will be there. Yeah. Fire. This is a anterior. So you wanted to take 3 more on the
On the left
left side. Now this is
Right side all.
right side.
3 ways.
Right side axial middle part of the base.
Yes.
Yes. Now we will take the left side three things. One is left lateral sagittal, left medial sagittal, and left center axial. Middle part of the base part of the prostate, because base part is the one which is shown. Now you are in which position?
Now I am in showing the left gland.
End firing.
End firing.
So you want to start with end firing?
End firing of the left side. Peripheral
Left side, go. There, be careful. In the middle you keep. Yes, in the middle, entire gland transitional zone up to the anterior part, fibromuscular stoma also will come. This is left side axial middle the base middle part of the gland. Now we will go to the
One more biopsy in the same region.
two biopsies we have to take. In the not here, we have to change. We have to go to the transitional zone. Sagittal zone as well as the sagittal zone, and one more.
T you press.
Ah.
Transverse.
But only one will come. Now here both if you want to come.
T if you press.
First if you press transverse, and then if you press this
Bipolar.
sagittal will come biplanar. This is a two one. Now you have to take only two pieces.
Yes.
One is again we'll show this center. Yes, the base. This is the base.
Yes.
Base on which side you want to take now?
Left
Left lateral medial. First you are taking lateral or medial?
Medial.
Medial. Turn this side a little. Yes. Now left base medial peripheral zone sagittal. Fire. Yes. Left basal region median sagittal. Now nice piece has come. Okay. This is the 17th piece. Now coming to the 18th, last one. 18 is okay?
Yes, sir.
Yeah. Now we are going to the most lateral basal part, sagittal view, peripheral zone we are taking. Fire. Yes. This is the last thing. So entire procedure patient did not have any pain. This is a good piece. Thank you very much, Soundarya. Now okay, when you insert you wanted to check for bleeding. Can you show here? Is there any bleeding? We will show if the bleeding is there. You wanted to keep for some time. No bleeding.
No bleeding.
So here no bleeding. Very well done. So we will keep pad for something. Thank you Andy. Cooperate చేశారు. అయిపోయింది. Don't worry. Sleep for some time. We don't change the position for some time. We will sleep in the supine position. After half an hour, we have the IV antibiotic. We have the IV line also, and anesthetist monitoring and anesthetist supervision. So with this, we want to conclude that if any object is there, if we have the banana is there yesterday, not there. So what the important aspect we can see is, if this is the prostate, what we have done now is, see first this is the prostate. If it is right, if it is left, this is anterior, this is posterior. This is the base, this is the apex. So we are traveling posteriorly, base like this in sagittal, and base like this, and base like this, base like this. Whereas when it comes to here, there is no periphery. We are traveling anteriorly so that most of the piece comes. In this part of the apex, we are going axial. 1, 2, 3, 4. In these two parts, we are going 1, 2, 3, 4. 1, 2, 3, 4. So 4, 4, 8 plus 4, 12. This is basic. In this part of the base, they said that lot of tumor is there. So we have taken extra 1, extra 2 and extra axial. Here extra 4, extra 5, extra this thing. This is the model. So if you take all axial, you take like this. So the thickness of the periphery will be less. So only axial in all regions is not correct. That's why monoplanar biopsy is not ideal unless it is in the apical tumor. Only apical region we can take it. So with this, we have been doing the transrectal ultrasound for last 15 years. First 10 years we are 10 to 12 years we are doing with ultrasound probe Philips. Now we are switched out to BK ultrasound. We are understanding better. Most important in sagittal is rotation, not the up and down. In sagittal it comes from side, so if you rotate, it comes from the right to left. If you rotate anti-clockwise, it comes to the more right. So rotation is more important in sagittal section, whereas axial up and down is more important. Thank you, and I hope this video will be useful those who wanted to do prostate biopsy. Thank you, Chandra, for nice demonstration. She is doing a lot of research on the ultrasound guided puncture of the patients all. So she got experience. She also does post-operative ultrasound for all the cases of the PCNL to see any collection or RS any collection in residual stones, and post-void residual urine also as an office ultrasound. That helps a lot to understand the structures of the muscle, colon, everything. Thank you, Soundarya.